Thanks all for coming. This is my first time presenting, at this type of meeting. And usually I turn up to ACR really to just escape the real world. And this is the very first time I think I've looked at the abstracts before getting to the meeting. And my brief was to look at rheumatoid arthritis treatment. And I was amazed that there's over 200 odd abstracts and we had to pour through that. Rebecca Granger's was rheumatoid arthritis, everything else apart from treatment. And so between the 400 plus abstracts, we've kind of drilled it down to about 20 slides. And this is what you're going to see. So part one is the non-treatment bit. So we all see people who have positive autoantibodies and a few aches and pains, which when we examine them, we're not quite sure, and we're not quite sure what's going on. But given that window of opportunity is so drilled into us, it's very tempting to do some sort of radiology, see synovitis, and then treat them with DMARDs. So this study was trying to address whether or not we should be starting DMARDs early. And it was a Dutch study. There were 3 arthritis cohorts with obviously very, very early symptoms and positive serology. These patients, 2 cohorts had ultrasound, 1 cohort had MRI, and of the 30-something odd % of the cohort who had subclinical synovitis at baseline, this group was then followed for 1 year. And the bottom line is that if you had ACPA positivity, 44 to 68% in the 3 cohorts did not develop early inflammatory arthritis at 1 year. And of the ACPA negative group, 66 to 89% never developed an early inflammatory arthritis. So the conclusion of this paper is that you probably should avoid over-treating people who just have subclinical synovitis. But there's another way to look at this, actually, that I was thinking about this afternoon. Because if you have ACPA positivity, so let's say you have a high-level CCP, what this is saying is that 44 to 6, well, about half of them actually do become, an inflammatory arthritis. So if you really truly want to treat at the window of opportunity, maybe you just treat those people. Yeah, I think you can read it that way as well.
So the challenge when I get to the challenge is to try and identify those people. As you said, we've known for 20 years that aggressive early therapy results in qualitative and quantitative better outcomes for people. So how do we identify those people?
So no, but some of us, yeah, sorry, I was going to say some of us might argue that methotrexate is pretty benign in a very early group that doesn't have multiple morbidity, and giving a little bit of methotrexate for a year, maybe switch something off. Not that big a problem.
I guess so what's interesting is that this group also, they didn't present it this year, but they've previously published that MRI detected tenosynovitis predicts development of rheumatoid. And in fact, the Leeds cohort have also shown that tendinitis of the extensor tendons of the hands is predictive of development of rheumatoid. So maybe we shouldn't be looking for synovitis, we should be looking for tenosynovitis. I think for me, it's interesting though, there's a little bit of mixed messages coming out of those early arthritis cohorts, which is treat aggressively and hard, but don't overtreat. So I think again, we need to use our clinical acumen.
Okay, I'll move on to the next one. In this one, it's a large study of an early arthritis clinic in the Netherlands at Leiden. And they looked at 772 consecutive patients who presented to the clinic, and they were given prompt conventional DMARD therapy. The majority were given methotrexate, and they were followed up to 7 years. And what they wanted to see was whether there were anything that predicted sustained DMARD-free remission, okay? And the definition for sustained DMARD-free remission was not having any RA after 1 year of DMARDs and no flares on follow-up. And I think, basically 19% of people entered this sustained DMARD-free remission. But as you would expect, only 10% of those were people who had ACPA positive. And I think we all tell patients who ask us, should you stop medicines, and we typically will tell them if you're ACPA positive, there's a very low chance of you being in sustained DMARD-free remission, and if you're ACPA negative, you're probably more likely to give that a chance. Now, when they looked at the groups, particularly the ACPA negative group, sustained DMARD-free remission was very highly associated with the most rapid decline in your DAS28 in the first 4 months. So I'll show you the next slide. And essentially, the lower your DAS at the 4-month mark, the more likely you were to be in sustained DMARD-free remission. Now, if you think about that, it's probably what, again, you'd expect. If you started someone on treatment and you saw them in your 3-month or 4-month follow-up and they haven't responded, right, you probably know that you're in for a tough course. You're going to add combination, or you're planning for this person to be on a specialized DMARD. And if they did awesomely well, you know, you're laughing, right? You're starting to take away therapy, or at least keeping them on just the methotrexate and taking away everything else. So I'm not sure it tells us anything more than we already know, but it was a big study, and it's nice to see this kind of work. Helen, any other take homes from you?
I think the thing to remember about this study is it's observational. It wasn't an RCT. So we don't know whether it was aggressive therapy that dropped their DAS28, or these people were just a good prognostic group anyway. And I think, again, it's sort of juxtaposed against the slide earlier saying let's not overtreat. So we kind of heard let's not overtreat, and then we're hearing you've got to get people into DAS remission really early. It's hard. It's hard to know. I think, again, let's use our clinical acumen. We know what poor prognostic factors are, and we treat those people really. We try and treat those hard once we know they've got rheumatoid.
Yep, and in both studies, really, when you look at the ACPA negative group, particularly in an early arthritis or pre-arthritis context, you don't really know what that group is. Maybe it's just a self-limiting arthritis anyway.
This is true, and I have to, if we've got time, which we probably haven't. Oh, we're on slide 3, so maybe we do. I was going to say, when I was in Leeds and we used to do these clinical trials, and we'd, you know, very early rheumatoids with poor prognostic features, we'd put them in trials of biologics, and that'd be their first line therapy. And then we'd see them at a year, and they'd have no signs of rheumatoid at all. And I used to always wonder if they were really rheumatoids or whether we'd induced remission. Or actually utilise that window of opportunity to reverse the disease process. But the evidence suggests that we haven't been able to do that. Rheumatology showed it with methotrexate early on. There's a couple of studies out of Leeds, one written actually by Sally Cox, the Empire trial using Dataset, and there's an IDEA trial using infliximab. So we haven't been able to prevent the development of rheumatoid using these drugs. So maybe these people who do really well were just always going to do really well. I don't know.
Yep. Okay, we now move on to CDI. Now, I work in a private group with 10 rheumatologists, and it's very sad to say that, you know, to this day, none of us uses some sort of outcome measure with every patient with rheumatoid every time we see them. It's a bit of a hodgepodge. CDI is quite a nice, obviously, outcome measure. It doesn't need the CRP, and this slide really synthesizes 2 different abstracts together. In the first one, it's 1,582 patients in a Canadian cohort based in Ontario. And what they wanted to do was to look at whether CDI correlated with the DAS28 CRP ESR. And I think the bottom line is that it does with moderate or high disease activity, and it's less good when it's low disease activity or remission. And the argument here is that with the CDI, the patient global takes a much larger chunk of that scoring, particularly when you don't have, you know, the CRP or the ESR. So really all they're saying is that they do correlate, but at the low disease activity remission level, you really have to look quite carefully at the patient global and try to understand why it is the way it is before escalating treatment just based on that. The second study is quite useful in this context of telehealth. So it looked at a US and a Canadian cohort, and they looked at patients where you had both a physician-derived joint count as well as a patient-derived joint count. And how they got the patient-derived joint count was that the patients were not trained. They were just given a homunculus where the patients recorded swollen and tender joint counts. And there was good agreement, basically, between the physician and the patients in about 2/3 of the time at both low and high CDI categories. I'll show you the second slide, which basically says that. I don't really know what a bland Altman plot is. This fish diagram, I think, is meant to suggest that there is good agreement. And that's a nice thing to know. And I firmly agree that I think patients should be involved, and patients can count their own joints. And often if a patient's telling you a joint's painful and my 4 fingers can't actually detect synovitis, the patient's probably right and I'm probably wrong. Helen.
So I think with regards to the first one, you said that in your clinical, you guys are experienced. You're a big, busy practice. You see a lot of patients, a lot of you. You've been a rheumatologist for 20 years. You know what you're doing. And I think that's really what the point of the first one. The CDI is a tool, but that's all it is. And when if you're using your clinical judgment, if the CDI doesn't fit with what you clinically suspect, then go with what you clinically suspect. It's a tool and nothing else. It doesn't replace the clinician. I think the second one, it's pretty relevant in the days of where we're being forced to do telehealth. But I'm just going to give a shout out to Rebecca Granger again, who I know she's listening. She did some groundbreaking work that she presented at ACR last year, showing that patients could score their joints on an app remotely, and that it was pretty comparable to what the physician would have scored, and didn't change their disease activity greatly. So this provides really some external validity to the work she's done, and it's reassuring knowing that we can still see our patients over the phone if we have to.
I filled in 8 PBS forms today over telehealth with a patient joint count, which was basically, I feel good and there's no swollen and tender joints. So yeah.
Excellent.
All right, we're going to run through a range of multi-morbidity slides now. And I think, look, we all practice in different settings. Having chatted with you, Helen, you are in a public hospital clinic, and I think you mentioned that it's rare for you to see a patient over the age of 60 who's not obese with RA. One of my practices is in the lower North Shore, and I thankfully get to see people who are quite early in the piece where RA might be their only problem. So there's a whole range of RA patients we see, but in this study, they looked at multimorbidity, and they used 2 large databases, one called MarketScan, which is a commercial insurance database, and they looked at patients over 2006 to 2015, so a big long-term database, and they looked at the Veterans Health Administration database for about 15 years of data. And the real-world commercial database is mainly female, the Veterans database is mainly male. And I can't remember the numbers. They collected 340,000 patients, right? And of that group, they looked at the people who had RA and the people who had non-RA. And then they used some sort of machine learning algorithm to analyze the rest of their comorbid diseases. And what the figure 1 shows you is that both RA patients and non-RA patients actually had similar patterns of comorbidities. It was just that patients with RA had higher prevalence of comorbid patterns. So I think we all probably know this again, but it's a reminder, because again, in discussions with more experienced colleagues, they often tell me RA is now easy to treat, right? We've got good technology, good drugs to do it, but I think it might be easy to play around with the drugs, but to try to really treat the whole patient, to deal with their mental, their emotional needs is actually really hard. Yep.
So, Erwin, I'm going to ask, if you're worried about obstructive sleep apnea, what's the mnemonic?
I know you guys talked about this, but I don't know the mnemonic. Sorry, I don't know. You got to help me out.
Well, I learnt on Thursday at Cornerstones, it's stop, bang. Anyway, I'll leave you to Google that with in safe mode. But yeah, I think we need to spend more time with our patients than we get. So There's nothing we didn't know, right? We know that our patients, well, my patients certainly have comorbidities. Yeah.
Okay. Following on from that is a RISE registry study. The RISE registry is a US-based electronic health record registry. I think it's the largest one in the United States. And what they did here was to look at adults with active RA who started on a DMARD, and they then followed those people for 1 year. They then used something called RX-RIS, which is a really cool way to work out multimorbidity by looking, sorry about that, by looking at the medications that those patients actually are on. And if you have an RX risk greater than 5, that's the definition for multimorbidity. And if you look at, I suppose, the tables on the other side, patients with RA had 9 to 10 comorbidities, right? And 50% were on glucocorticoids. So this group of patients in the RISE registries, Americans, have multiple comorbidities. And what they wanted to see was whether having lots of comorbidities in the real world prevented you from starting DMARDs, but they didn't show that. Even with multimorbidities, we as rheumatologists are not scared to start people on DMARDs. But the odds of actually achieving remission or low disease activity, at least as measured by CDAI or rapid tree, were lower when you had more comorbidities. Again, an important thing for us to know. Obviously, it argues to, if you can treat people early before they increase their comorbidities, and we need some better handle of dealing with comorbidities as well. Yeah.
I feel a bit like in the public hospital system, I'm futile when I read that because they've all got, so much comorbidity. Yeah.
It's a bit sobering.
Well, I also think it's sobering how many patients are on steroids. So 50% of patients on glucocorticoids. I think you'll present some data later that will remind us that they're not a good thing. And perhaps it's time for us to all just reflect a little bit around with the VIP grant the ARA did. We would have all recently found out how many of our patients are on opioids, how many are on steroids, etc. And we should be looking at that.
Yep. Now, this is a good study. This slide collects 2 different abstracts. And I mean, we all see patients who've got non-alcoholic fatty liver disease. And often it's hard because you're looking at blood tests and you're thinking, should I reduce the methotrexate? Should I not? So the first study looked at 235 patients in a hospital population who had a liver CT versus non-RA controls. And they showed that non-alcoholic fatty liver disease was definitely more common in patients with RA, and it was strongly associated with alcohol. They managed to show in this relatively small group of 235 people that current use of DMARDs was not associated with non-alcoholic fatty liver disease. So that's a good thing for us to obviously know. If you're wondering about the scale on this, because I had to look it up, HU is Hounsfield units, and apparently the lower the HU, the worse steatosis. Okay. The second study was a Korean hospital study, and they looked at RA patients who had ultrasound and look at the differences between those who had non-alcoholic fatty liver disease on ultrasound versus those who didn't have it. And it's what you would imagine. The people with higher BMI and higher triglycerides had higher levels of non-alcoholic fatty liver disease. But the good news from, admittedly a small number, 92 patients, was that there was no association with methotrexate. So that makes us feel a bit better, more comfortable with doing it. Non-alcoholic fatty liver disease, I usually say to patients, is due to weight, cholesterol, alcohol use, and perhaps disease activity, not due to their drugs. You agree, Helen?
So just with regard to the first abstract, was the steatosis associated with obesity and lipids?
They didn't report it in the abstract that I have in front of me. Yeah, so no, I don't have any specific mention of that. They pointed out the alcohol.
So the alcohol, just to clarify, was it people with rheumatoid drank more alcohol, or alcohol or
the patients with rheumatoid arthritis who drank alcohol had more were more likely to have steatosis than those who do not drink alcohol at all.
Right. Yeah. Okay. All right. So again, we should be talking to our patients about how much they're drinking, managing their lipids. I mean, the temptation is always to leave that to the GP, but I guess we should be flagging it to them, and also their weight. Again, as I mentioned, all my patients are overweight.
Now, this is the final 2 slides on multimorbidity. And again, the RISE registry. I won't labor the point, but if you just look at the table, they looked at RA, PSA, OA, gout. So our typical patients, right? And look at the RX risk scores again. I told you that more than 5 means comorbidity, multiple comorbidity. And, you know, it's a 7, 8. So across the range of the patients we see, they all have multiple comorbidity. And so, you know, Rebecca made the statement that it's no surprise we're tired after a clinic. But this is good data. It will justify why Australian rheumatologists like to use the 132 item number. And we are fully justified in using it because our patients have multiple comorbidities, right? Yeah. And if I show you the last slide here, the prevalence of multiple morbidity, so that the percentage of people with greater than 5 of that RX risk is actually highest in gout. And when you look at the burden of multimorbidity, i.e. the number of multi-morbid conditions, it's also higher in gout, right? And I think, yeah, you know, for something that should be treatable, yeah, it's just so hard, gout.
And what's really interesting to me, Erwin, is that we know it's badly treated, but no, most physicians would refer rheumatoid, they'd refer psoriatic arthritis, they don't bother referring gout. And we've shown that again and again and again. And these people are actually much sicker than most of our rheumatoids or our psoriatics or even our OAs. So we need to refocus on gout. I know this is the RA section, but it's an easy disease to manage and it's badly controlled, and their comorbidities are ignored as well. Before we move on, sorry, we just had some questions. Raise them. So before we move on, question from Estine Chow, talking about the Steatosis abstracts. She asked the question, are we justified in continuing to use DMARDs like methotrexate if the LFTs are continuing to derange?
I think, you know, the stuff I just presented is nice to know, but in a real world scenario, you'll be very brave if you continue to give methotrexate and the liver tests continue to increase and worsen, right? Most of us would either reduce the dose or play around with folinic acid or, you know, whatever your favorite potion to try to help the liver tests are. And of course, if they keep increasing, you'd just be checking them more regularly, and ultimately you might stop the methotrexate, irrespective of what I presented.
So yeah, absolutely. The next question is, does fatty liver increase the risk of hepatotoxicity prior to starting a DMARD? And my understanding is it absolutely does increase the risk. If you've got fatty liver before you start the methotrexate, you're at increased risk. So good to know. You can screen for it fairly easily with a FIB4, or these days we have FibroScan in my hospital. Again, I'm not in private practice, but I can fairly easily get a FibroScan done.
Yep.
Okay.
Okay, part 2. We now go on to the treatment part. Whoops. Okay. I think all of us either treat or have seen patients who've been left on a couple of milligrams of prednisone for a long time. And a lot of patients feel better on it. Every time they try to reduce it by 1 milligram, you know, they flare, and so you end up just accepting it. This is a paper from the Espoir cohort, a French collection of early rheumatoid arthritis. And what they did was they followed up 608 rheumatoid arthritis patients for 10 years. These were patients who never had a prior event, which of the composite outcome that I'll tell you about in a moment. And they divided the group to those who had even any dose of glucocorticoids versus those who did not get glucocorticoids. And the composite outcome measure at 10 years was all-cause mortality, coronary vascular disease, severe infections, and fractures. From the results, you'll see that 65% were given glucocorticoids at least once. And if I look at my own cohort and how I treat, yeah, I would say at least 2/3 I give a little bit of steroid to. The median dose was a small dose, 1.9, but the cumulative mean dose was 8.4 grams, okay? And you can see that 55% received glucocorticoids for more than 2 years, mean duration 44 months. And when I first saw those figures, you could say, well, no, I don't do this in my practice. But when I got those NPS medicine, you know, that biologic use survey data that was individualized to my practice, it's surprising how many of my patients are still given a bit of prednisone, not, you know, some by me, but a lot by some other practitioner, presumably their GP. And I think that data was very interesting, and it'll make me kind of obviously ask more questions to my patients. But I digress. And when you do look at the group who got a cumulative dose greater than 8.4 grams in that orange box, which isn't actually that much, 5 milligrams a day for 5 years, or that equates to, you know, 2 to 3 milligrams for 10 years, which we all have. The primary outcome was found in a quarter of them. Okay, and more interestingly, if you look at table 1, it really takes off after a length of time. So as you hit, you know, year 6, 7, 8, 9, 10, you can see that the hazard ratios really increase. Now, the main, I suppose the main problem with this study is that the glucocorticoid group obviously had more active disease, and they couldn't kind of control adequately for that. But I think it's a reminder that even leaving on someone on a couple of milligrams a day might not be as benign as we kind of thought. Helen, any comments on that?
Yeah, so I think, you know, this is very much what we're hearing from Eric Moran in Lupus. Long-term steroids are bad, but I think we also should reflect that long-term low-dose steroids are bad. But if, you know, we were talking earlier about trying to aggressively get people into remission early, and all of those early studies used steroids, Cobra, Tacora, Finraco, Best. They all used steroids, short-term, moderate to high doses, to get people in remission, and really didn't show adverse outcomes. So I think this is just a reminder again, short-term steroids are probably okay, long-term steroids are probably bad.
Yep. Sorry, I just added something to the chat box. People can chat among themselves there so that they can see each other's questions. Okay, next one.
I can see the screen and the questions, so you can deal with the chat.
All right, next one. I really like this. This is my favorite kind of abstract and presentation there. And that's because despite the mantra of needing to use methotrexate with TNF inhibitors, I think in practice, TNF inhibitors are often used as monotherapy in RA. And the last time I audited our own group's kind of biologic DMARDs, I think about 40% of patients with RA on TNF inhibitors were on monotherapy. Now, I don't think that the physicians don't know the data. I think that most patients either, you know, eventually, if they're doing well, dump the methotrexate, or, you know, they argue the point of a trial without methotrexate. Okay, so this trial tried to answer whether you should drop the etanercept or methotrexate from a combination etanercept-methotrexate strategy in a group of patients in sustained remission. Okay, and the definition of sustained remission they used was an SDI of less than 3.3. Now, I don't use the SDI, but I think from what I understand, that's quite a good and a robust remission kind of indicator. And you can see that they have a run-in period of about 6 months. And during this run-in period, once they've identified the patient, they wanted to ensure that that patient actually stayed in a good sustained remission before they were randomized. And they were randomized to a 2-to-1 kind of distribution. Either you were in the group where you continued etanercept and you just dumped the methotrexate, you were in the group where you continued the methotrexate and you dumped the etanercept, or you continued on both etanercept and methotrexate. And the primary endpoint was the maintenance of the SDI of less than 3.3 at 48 weeks. Okay, and here's the results. So I think the first thing to look at is the combination therapy group. And at the end of 48 weeks, only 53% remained in SDI remission. So this is a reminder that, you know, we see fluctuation in rheumatoid arthritis, and this happens even in people who are well controlled. Now, the next thing to look at is the etanercept monotherapy group. You can see 49.5 versus 52.9, and that was not a significant difference. So the vast majority of people who were just on etanercept alone matched the performance of the combination therapy group, right? If you dumped the etanercept and you just remained on methotrexate alone, you did not do as well. And flares typically occurred in, you know, in the 3 to 6 month period, and you know, it's only 28% maintain SDI remission. So almost what's that? 45% less than the other two groups. So I think this at least is reassuring for those of us who have patients on TNF monotherapy. I do appreciate that this is etanercept. It's a CEP, it's not a MAB. So it'd be nice to see this replicated with a MAB, because you know, everyone can argue about anti-drug autoantibodies. The other thing to say is, even if you made the wrong choice and people flared, I think 70% plus were rescued very easily by getting back onto the combination and got back into sustained remission, but the vast majority got into low disease activity. Okay, it's also nice to see this because we've recently had our Australian Living Guidelines launched, suggesting that we consider halving the dose of etanercept, i.e. instead of injecting it once a week, you inject once a fortnight. But the problem with that, and actually that's what I tend to do now, but the problem with that is you're still left on 2 medications. And, you know, most patients, and I really would like to be minimalist and be only on 1 drug if you can. Yeah, so I think this was a really good study.
Yeah, I think it's, so the other thing to say about this is, as we've been talking about steroids, is that there was people were allowed to be on steroids in this, weren't there? There was a proportion of patients on long-term steroids. Yeah,
they were allowed less, sorry. It was less than 5 milligrams, but it's actually the minority of patients.
Yeah, so they're actually on 3 drugs. And if I was going to stop 1 drug, I'd probably want to stop their steroid rather than methotrexate or their etanercept. So that was a curious thing. I think it just speaks to how tough it is to stop people's steroids. And actually, Rebecca's pointed out in the chat that most cohorts have 20% glucocorticoid use. But, you know, the other thing about this that's a bit reassuring is that, you know, we know our patients don't take methotrexate, and most of them are on monotherapy etanercept anyway, even if we're prescribing methotrexate, so they're still going to do okay. And again, if you want to play around with their drugs, try withdrawing something, then you're going to recapture disease control if you need to, in the vast majority. So that's reassuring.
Okay. All right. The next 5 or 6 slides all pertain to JAK inhibitors. So apologies to my New Zealand colleagues with us, because you don't have those yet, but hopefully you'll get access to them very soon. This is the starting slide to introduce the topic. And this was, I thought this was useful because I've combined 2 abstracts from the OPAL group. The OPAL data set and the OPAL group is about 110 Aussie rheumatologists who all use the same electronic software. And that electronic medical record can automatically pull out data. So they've been quite productive in generating research topics. And so what they did here was to look at prescribing patterns in Australia, in community practice mainly, from January 10 to December 14, and they then compared it to January 15 to December 19. And if you look at the results column, not surprisingly, the bulk of prescriptions were for TNFs, then tocilizumab, the IL-6 inhibitor, then a bit of abatacept, and a small number of rituximab. And they did look at cycling as well, and 58% of people who received the TNF inhibitor as first line swapped to a second line TNF inhibitor during those first 5 years. Now, if you then look at the last 5 years, there's a massive shift, right? 28% JAK inhibitors. I think Australia is #1 in the world in the uptake of JAK inhibitors in RA. So, you know, more than a quarter are now on JAK inhibitors. And understandably, the TNF cycling has reduced. Only 40% of patients receiving a TNF in first line swap to another TNF in second line, presumably because, you know, people are swapping more to the other agents and presumably to a JAK. It's interesting that they recorded 3 different reasons. They had so 4 reasons: lack of efficacy, better alternative, adverse reaction, and other. And you know, half of them was for lack of efficacy. 27% was this nebulous concept of a better alternative, and about 19% for adverse reaction. So figure 1 is from a separate paper, and the first blue line is tofacitinib. And when tofa was introduced, you saw a spike in scripts. The second line, which is the orange one, is baricitinib, Olumiant. And when Olumiant was introduced, there's another spike. And you can see the numbers of tofa dropping. And the most recent one, I think we got it in April on the PBS, was upadacitinib. And you can again see the spike of UPA in this group with reduction in tofa and baricitinib. This is an interesting spike. Some people have argued it's because, you know, a lot of people swap their grandfathered patients onto the PBS. You know, I typically don't use the patient familiarization kind of scheme. So in our own practice, it's just us wanting to try the new drug. And I think we see the same sort of pattern. And if I audit myself, I'm sure I'll see the same pattern given I like to try the new drug. Yeah. So it's interesting to speculate on how we make our choices, really.
So what do you think, Erwin? Well, you said did you just say you like to be at the cutting edge of technology?
No, I think I think when a new drug comes out, and because I'm not a trialist, I really don't have experience of it. So I like to, you know, if the choice is between baricitinib and upadacitinib for a patient in front of me, I might try UPA for a few at least to get a bit of a feel. And that's what I tend to do.
Should JAKs be first-line therapy? I mean, this was the great debate this year at ACR.
It's a great question, and I think it all depends on the patient in front of you, right? We've had this debate. I'm quite a fan of JAKs, and you prefer TNFs, and of course I still use TNFs. It just depends on the patient in front of you. And as you'll see from my next few slides, it depends a lot about safety and which population you use. And perhaps at the end of all those slides, we'll open for questions because I think, you know, there'll be a few on this. Okay? Yeah.
So I think that's an important point. You and I see a different patient population, and I've seen some bad stuff using JAKs. So, and to be fair, I think using them in young people has its problems as well. So let's we'll move forward and maybe talk about that as we go along.
Okay. So we needed to put this in because the main concern with JAKs is that you don't have long-term safety data, right? So this is the baricitinib data. It's up to 8.4 years in a long-term extension trial. It's from their 9 completed RCTs and this ongoing long-term extension trial. And so, you know, it's as good as we have at the moment. And what is nice to see, because of course our fear has been kind of side effects. The first thing to say is the VTE risk looks to be stable over time, right? Even though the longer you're on it, the incidence rates don't seem to be increasing. So that's the first good thing. If I show you the next slide, let's look at the herpes zoster. Again, we do know herpes zoster is more common in this drug population, but it's nice to see that you're not seeing a spike over time. Now, if you look at the severe infections, you get the same message, right? You do have more infections if you're older, for the greater than 65-year-old group, but again, over time, there is no clear-cut increase. When you look at the under 65-year-old group, it's quite interesting that with serious infections, there's not higher than placebo. So I think overall, it is what you know. You have to worry about herpes. There remains a question mark about VTE. And, you know, we're going to be cautious, but there's no worsening signal over 8.4 years.
So I think it's interesting. you know, the temptation, I think, is to use these in elderly people because they're a tablet, they're easy, and that they're probably the people at highest risk of adverse events. We don't have a good vaccination for zoster. And actually, when you were talking about the risk, you know, intuitively, I would think if you've had zoster, you'd be at high risk of having it again. But you were saying that's usually not the case.
Yeah, so a few slides from now, I'm going to show you some zoster-specific data. And of interest was that one of the predictors of more zoster was previous zoster. Okay, so we'll come to that soon.
That's only in people with rheumatoid. In other people, they don't. If you have it once, then you're okay.
Agreed. It was a surprising.
And the other thing that I find most concerning about the VTEs is there's still no plausible explanation. So how do we're using a drug, we know it causes side effects, and we don't understand it at all. And the side effects are potentially fatal. So, you know, for me, that's incredibly concerning. But anyway.
Yep. I understand your concern. That's why I picked the next paper, which is the risk of VTE among patients with on OPA. And obviously, OPA had a very extensive trial program. And this is data from phase 3, 5 randomized controlled trial data, and looking specifically at VTE. Bottom line is very low numbers of VTE. Most of them were PEs rather than DVTs. As expected, you'd have increased VTEs with age. If you've had a prior VTE, you had a longer duration of RA, presumably more comorbidities for a longer duration of RA, higher body mass index. And if you look at UPA 15 milligrams, which is what we have in Australia, UPA 30, and then the comparator groups, which was the monotherapy group and the adalimumab group, there's no increased VTE risk compared to the comparator groups. Now, is this enough to, you know, kind of satisfy your worry, Helen? I know the answer is no, but it's one step towards it.
I think, well, I think, you know, when we're all burnt by our clinical experience, right? Like we learn from our own clinical experiences. And mine have been that I've still had clots on this drug. So until we understand it and can understand who's at risk and who's not, and the patients I've had who've had clots on these drugs have been anticoagulated for AF and had their anticoagulation muddled with a little bit because they were having a pacemaker put in or something. And you know, you should be able to do that without the patient having a massive, almost fatal PE. So I just am happy to watch this space. And I think, you know, the other thing is the EMA suggests that we shouldn't be using these in people over 60 unless we've got no other choice. So for me, they're not first line in people over 60. And, you know, I worry about pregnancy in young people. So, yeah, we'll, you know.
I don't disagree with you. It's, you know, patient selection at the moment until we get more and more data. But the good news is, I mean, there were so many abstracts on JAK inhibitors, right? There's this massive shift. And obviously, yeah, obviously we're going to get
it's amazing. Yeah.
Okay. Now, I want to show you the flip side, which is the herpes risk. And Kevin Winthrop, you know, presented lots and lots of safety data. And this was a really interesting one, looking at the herpes zoster risk. So we do know that with the JAK inhibitors, right, there's an increased risk of herpes zoster. We saw that with TOFA, we saw that with Baricitinib, and it's definitely there with upadacitinib. And it's 3 times higher, basically, on UPA 15 milligrams, right? And it's 5 times higher on UPA 30 milligrams. So it's clearly more common when compared even with the comparator groups of adalimumab and methotrexate. Interestingly, and thankfully, the majority of cases were single dermatome. You already mentioned this, but Kevin Winthrop spent a bit of time talking about this, that it was quite surprising to them all that prior history of herpes zoster seemed to predict, was a risk factor for getting herpes zoster in this trial patient groups. He said that is not what is expected in a normal population, and could the drugs be doing something different to these people? But no one understands why. you talk about things we don't understand, it's clearly higher risk in Asian regions, particularly in Japanese. They seem to see very high rates in Japanese. Why is that? No one really understands that as well. But we already do know if you're an older age patient, that's a higher risk. So clearly a zoster signal. It would be nice to have Shingrix here because, you know, as a group, I think we fail with vaccinations at the right time, and it's a very difficult thing to address vaccinations at the time you want to start one of these drugs because of the other drugs you're on. Yeah? Okay.
Yeah, and then we need it to be available to our patients for free. And then there's still going to be a percentage who don't seroconvert and aren't protected by that. So, you know, Shingrix is a great start. And there's also not good guidelines about how we should, when we should vaccinate, how long we should withhold the drug beforehand and afterwards. So it's still a bit of a mess for us, really.
Agree. Yeah, AbbVie should buy whatever company makes Shingrix and, you know, just package it together. All right, now, I had to give you this one as well. So filgotinib is going to be the 4th JAK inhibitor on market. So when you're 4th on market, the question is, why the hell should we use it, right? I mean, the efficacy data is good. It has a comparator against Humira, there's superiority data, but you already have that with upadacitinib. So the question is, and I think you're going to hear a lot of this, is the fact that it's JAK1 selective, does that mean that it's safer, right? And so this is now quite intriguing data up to 5.5 years. And to summarize, you look at the MACE, look at herpes zoster, look at malignancy, look at VTE. There's no actual signal of these things. So if you're going to use a JAK, Helen, I would choose this JAK for you if this bears out in clinical practice. So no zoster, no VTE. You know, yes, it can affect male sperm. I know, but you know, majority of patients are female.
Yeah. So look, you know, the data for these drugs is really amazing. And, you know, this drug blocks JAK1, just like UPA. Yep. So hopefully it has the same efficacy as UPA. And we know, you know, I don't know why it's got less risk of zoster than UPA. There's so much we don't understand.
Yeah.
But
I think this drug was actually owned by AbbVie as well, I think. And then they sold it off to Gilead. So hopefully, yeah, it might be a mistake. We'll see.
Yeah, we've got a lot. There's a lot in this space, isn't there?
Yep. All right. I think this is my last slide before I hand over to you. And it's another filgotinib paper. It's a quick one. Again, when you're 4th on market or you're a different drug class, why do people use it? Typically, they use it if they've run out of options, if you failed lots of other drugs. And so this was a way where they did a subgroup analysis looking at people who failed 1 DMARD, 2 DMARD, 2 biologic DMARD, 3 biologic DMARDs. And basically, filgotinib works in all 3 groups. Then they looked at if you failed IL-6 versus if you failed with TNF. And again, filgotinib worked in both groups. What they don't have, which obviously we're really interested in, is what happens if you fail a JAK inhibitor? You know, what if you fail tofacitinib? Should I swap you to a more selective JAK inhibitor, and will I get an effect? I think, you know, a number of us have tried these things and with varying success, but we don't have data.
So okay. What do you think about the concept? You know, people used to talk about the concept of primary non-response and secondary non-response. And if you had a primary non-response, you'd change class. Secondary non-response, you'd use within class. In your experience, have you seen that? If you fail,
I think we still do that, right? So let's say you started a TNF inhibitor, and the reason you swapped was not because of primary inefficacy. It might have been an infection or, sorry, a side effect or injection site reaction, or they were great on it for a few years, then they decided to stop the methotrexate on holiday, and then they lost response. Because they tolerated it so well and it worked, you might be very tempted to use another TNF inhibitor. So I think in that case, no problems with that. But I think for a lot of us, if you've used it and the response was kind of okay, but not amazing, and now that we're getting greedy and we want convenience and we want people to do better, they might have one wrist that's still swollen and you're going, maybe I can get you better by swapping. And some of us will and others won't. So I think obviously you need to have the shared decision. It depends on the patient's tolerance and your tolerance, and hopefully you come to some common ground before you decide to swap. But I will disclose that I'm a swapper of classes.
I think, you know, the concept of secondary non-response with regards to the TNF inhibitors was always hypothesized to be because of their immunogenicity, you know, and neutralizing antibodies. So it made sense to swap to a different class, but probably we won't see. I mean, who knows? We shouldn't see that with JAKs, presumably. So maybe with that concept of secondary non-response and switching within class is not relevant here. Okay, you get a break. My turn. So I'm doing everything else. So Scleroderma.
Half an hour, I'm sorry.
Take it away, half an hour. Okay, I can speak quickly. So Scleroderma. No, what are we on to first? Myositis? So Erwin's running the PowerPoint slides, so I'll have to get him to. So this is great. So this is probably my favourite slide of the abstract of the conference. So in 2012, there was a Cochrane review of RCTs in autoimmune myositis. And I think there was 10 studies with about 200 patients in them altogether. So really very little evidence in this space. And but what looked promising from that Cochrane review was IVIG. Then we had the RIM study a couple of years ago, which looked at rituximab, was 200 patients on its own. So it was almost as big as the whole body of evidence we had in autoimmune myositis prior. And as you know, that was negative, but we still use it because we think it works. So this study was IVIG in active dermatomyositis, 95 patients. Now, this is incredible because I've tried to recruit for autoimmune myositis studies, and they're so hard that you have to have active disease, and then akin to this, you get randomised to treatment or placebo for at least 16 weeks. So you need to be on conservative therapy, have active disease with quite significant weakness, and then half of you are going to get a placebo. So they managed to enrol 95 patients. There was an escape arm at 12 weeks, and then at 16 weeks, it was open label. But the primary endpoint, which was total improvement score, significantly different between groups, really, you know, unambiguous that IVIG works in dermatomyositis. So yeah, we can use this drug though in Australia. So I guess it just validates what we're doing clinically. Anyone, any comments?
No, really, as a private practice doctor, I have never used IVIG, but I'm glad to see this data. Yeah.
Side effect profile, as expected, 3 DVTs in the IVIG group because of the increased viscosity, but 2 in the placebo group. Who knows why? Okay. Next slide. Okay, so so this was 2 slides. 2 abstracts, sorry, we've merged into one looking at IVIG, and this has been put in here because we know how much everyone is fascinated by this disease. I personally have never diagnosed it. Erwin? No? Okay. So they're talking about the classification criteria, and they just looked at the performance of the classification criteria against the clinician's opinion, which of course is the gold standard. And this is from Emory group of hospitals. So the classification performed pretty well. So if you would if the clinician definitely thought you had IgG4, then 84% of them met the classification criteria. If the clinician thought they probably had IgG4, then only 5% met the classification criteria. So if you think something's probably IVIG, then going to get the classification criteria to help you work it out, it's not going to help. And then for the things that the clinicians thought were mimickers, none of them met the classification criteria. So I guess it's quite good at working out what's a mimicker and what's not. And then just looking a bit at what was a mimicker. What was referred to this clinic that wasn't IgG4 but was a mimicker, and most of them they were autoimmune disease or neoplasia or other. A lot of gastrointestinal disease, and indeed that was largely pancreatitis, idiopathic or recurrent pancreatitis, which is interesting given that this looks like autoimmune pancreatitis on biopsy. So again, difficult, you know, we've got a 3-minute abstract presented to us. So it's, and with no question. So a lot of information sort of lacking in this new format that is the ACR that's going to be presented electronically. But also of those with definite IgG4, 74% of them had an elevated IgG4 in the bloodstream. So not all of them, as we know. And yeah, some had about a third had an elevated ratio of IgG4 to IgG. So if something's atypical, you should repeat. The take-home message is if something's not definite IgG4, doesn't feel definite to you as a clinician, doesn't definite as a classification criteria, then rebiopsy, because malignancies were identified quite often when they did a repeat biopsy.
I'm really worried about this disease. They always talk about it, and I never see it. So I'm sure I'm missing it. It'll be interesting if, you know, the attendees write in the chat if they've got any of these patients. But yeah. I don't think any of us who prepared this slide deck have seen it. Yeah. Okay, we'll move on to the next.
Vexus that I saw last week though. So okay. So this is just looking at apremilast in active Behçet's disease. So this was a study where they took people with oral ulcers and gave them apremilast or placebo, and found really the take-home message from this is that they had an early response at 2 weeks, people's ulcers healed, and that it was fairly complete at 6 weeks, and that it was maintained for up to 12 weeks. So they also looked at musculoskeletal, so arthritis symptoms and skin symptoms, which were presented in other abstracts, which also improved, but not as impressively as the oral ulcers. So what do you think, Erwin?
I like apremilast. As I said to you, my only experience is with PSA, and it was good. But yeah, how do you get it for our patients here as well? I suppose they'll have to pay for it privately, because we can't get it here. Sure.
Improve apremilast for the treatment of oral ulcers. But anyway, it's something to keep up your sleeve.
Cool.
Osteoarthritis.
Any questions? Let's see. David mentioned something. Oh, David just says that he has many probable or possible IgG4 patients, retroperitoneal fibrosis, which seem initially steroid responsive. Yeah. And you know, like us, they all scare him. All right, we might move on to osteoarthritis. Okay, so my PhD was in osteoarthritis, and I felt very nihilistic about it for a long time, really. So this is a monoclonal antibody against nerve growth factor, tanezumab, and there's a whole series of studies presented at ACR. There was 3 clinical studies. It's marketed by Lilly and Pfizer together. So rather than present all of them, I've just pulled some slides, some data from the 3 and put them in one slide. So basically on the left, figure 1, these were studies comparing the investigational product against anti-inflammatories, and you can see that that it performs at least as well as anti-inflammatories and often better in regards to pain. And these are clinically significant reductions in baseline pain over time at week 16 and 52. So never worse than NSAIDs, often better, and it's sustained to 56 weeks. Then on the right, we've got against placebo, and greater than 30% improvement in pain, the 2 doses against placebo, and it performs, again, that's a clinically important difference in pain, and it's performing well. So, you know, what do you think? Do we have a drug for OA? Well, he has he hasn't bothered answering. He's just moved on to the next slide. So as most of you... It's the same drug.
Okay. What?
It's your second slide on this drug.
Okay. So the initial studies were halted by the FDA, and safety studies were made to be done because they were concerned about rapidly progressive osteoarthritis. So what they've done here and presented in this slide is they've taken a subgroup of patients from each of the 3 studies. It was about 451 patients. And then they've got a safety, sort of a data safety monitoring board, I guess, to look at the x-rays of these 451 patients, and that the primary endpoint is a composite joint safety endpoint. So they were looking for primary osteonecrosis, rapidly progressive OA, type 1 or 2, or a subchondral insufficiency fracture or a pathological fracture. And in these 451 patients, 145 had met this joint safety endpoint. So a third of patients you treat with this drug will have a pretty severe adverse event in the joint that you're supposed to be treating.
So this drug is dead, right? We won't get it.
Interestingly, this was a plenary, and the question was asked to the presenter, who would you treat with this drug? And he said, well, I'm a radiologist, so I couldn't comment. He also did say that Lilly and Pfizer were going to take this to the FDA and try and get it approved for use. So I'm not sure when it's as good as an NSAID and much more, well, arguably dangerous. I don't think I've...
David makes a fair point that, you know, how scared should we really be of a little bit of progression of OA in patients who are already heading towards joint replacement, right? Because we're so desperate for symptom relief, really.
It's not a little bit of OA, it's rapidly progressive. We're not giving people recurrent intra-articular steroid injections here. Primary osteonecrosis. So, yeah, these were quite bad endpoints, I think. I think, you know, again, how scared should we be of progressive OA? I think the problem is that we need to be focusing on preventing OA. We should be, as a world, as a nation, we should be spending money on obesity prevention strategies and sporting injury prevention strategies and rehab. So rather than trying to treat it once it occurs with mechanistic drugs.
Yep.
Anyway.
Agree completely. Now, from one drug to a more expensive drug, I think.
Yes, so another mechanistic negative study. So tocilizumab in hand OA, a 12-week randomized double-blind placebo-controlled trial. It's negative. 91 patients didn't reduce their pain any more than placebo. So the theory is, you know, it's anti-IL-6. It's thought to be anti-synovial, anti-inflammatory, and that most imaging studies show some degree. Most imaging studies show synovial inflammation in OA if you look hard enough for it, and some correlation with pain. You know, R value is normally of about 0.3, so not strong. We know steroids do decrease pain to some extent, so that's the theory. But this didn't work, and it's interesting. You were commenting about the steroid hand OA study that was positive.
Yeah, I wanted something to work, really. I wanted this to work, given prednisone kind of works. But yeah, this is so disappointing. Yet another drug that's bites the dust.
Yeah, unfortunately, preventing obesity probably will do little to prevent hand OA. But yeah, I don't know where we go with hand OA, really. Anyway, okay. Next, so this has been a controversial area recently. Are repeated intra-articular corticosteroids safe? Intra-articular. So this was a meta-analysis and systematic review and meta-analysis of RCTs. So they did both an efficacy analysis and a safety analysis. There were 6 RCTs kept in, included in the efficacy analysis, and the primary endpoint was looking at a reduction in pain at 26 months. And basically, they found that it's probably no better at relieving pain than comparators. And then looking at the safety endpoint, they found 14 RCTs and 2 observational studies they could include in that analysis. And unfortunately, there was only, they're not really sure. One RCT found that repeated intra-articular corticosteroids every 3 months for 2 years caused greater cartilage loss. And there's one cohort study showing that multiple intra-articular corticosteroids are associated with worsening of joint space narrowing. So multiple intra-articular corticosteroids are probably no better than comparators. They may be safe, but we're not really sure about their effect on cartilage.
Yeah.
What do you think, Erwin? Do you use multiple intra-articular corticosteroid injections?
Yeah, I think it's always interesting when patients come and say, you know, they've been told they can only have, you know, 2 steroid injections in their life and they're saving it up. And then I have other patients who want to come all the time, and you know, we give them that magic, I'll wait 3 months at least, or 6 months at least before I do it again. And we just have no data, no good data, right? And of course, we worry about cortisone injections, but I'm sure, like me, there'll be some patients where you do it, right? Because they feel so much better. And it then allows me to then introduce the physiotherapy, the mobility and the like, when you try to calm it down. So I don't know how this helps me. I think it won't change what I'm going to do. I'm still going to inject some people. And if it's a placebo, fine. If they get up and start walking and do things, no problems. And it's much cheaper than the stem cell clinic down the road.
This is first line, not the nerve growth factor inhibitor.
No.
Yes. Okay. we've got 15 minutes, so I need to talk faster. Okay. Gout. Okay. So Gout. So this is great work done by the New Zealanders. Their GP practices use electronic medical records, and they have a program in there, an algorithm which predicts cardiovascular risk. It's called Predict. So of 450,000 patients, 22,000 had gout, and when you looked at the GP's risk predictor algorithm, it underestimated the risk of cardiovascular disease in people with gout because they looked longitudinally to link data and found, so it underestimated the risk of heart attacks in people with gout and overestimated it in people without gout. Just a reminder again that our gout patients are very sick.
Yep.
Shall we move forward? So actually, when we see gout patients, let's remember, check their blood pressure, check their diabetes, check their cholesterol. Okay. This is possibly my second favourite slide from the conference. And really, I could talk for way more than 15 minutes on just this. So you're all familiar with the CARE study, which was mandated by the FDA, looking specifically designed RCT to look at the cardiovascular safety of febuxostat in gout compared to allopurinol, published in the New England Journal of Medicine about 2 years ago. The EMA also mandated a similar study. This is called FAST. So this was done throughout Europe. Slightly different from the CARE study. It had they didn't have pre-existing cardiovascular disease. They just had to have one risk factor. They were excluded if they'd had a cardiovascular event in the last 6 months. They excluded if they had severe heart failure. They were on baseline allopurinol, and they were switched to either febuxostat or allopurinol. It was open label. Bottom right graph, you can see they're the withdrawals. Now, CARE study had huge withdrawals, over 50%, I think. The withdrawals in this study were small, only about 5%, but way more in the febuxostat arm than the allopurinol arm, because the people on allopurinol, they were already on allopurinol, randomised to allopurinol or febuxostat. So you can imagine that makes sense that more people on febuxostat would switch, and it was would withdraw, and it was open label. But I think the bottom line is no increased risk of all-cause mortality, cardiovascular mortality, or MACE, which is their primary endpoint. What do you think, Erwin?
No, I like the message. Important one. Obviously, there are problems with the study. There were a lot of problems with the CARE study, with lots of withdrawals as well. And at least you have something to back you up when you're using it in this patient group. And gout's already so hard to treat. If you only restrict yourself to allopurinol, it becomes even harder.
So I think that the main criticisms of this study is it's sponsored by Menarini, although the presenter took great pains to say that they had nothing to do with the running of the trial. This study did not, so it was slightly underpowered because of their dropouts, and only a third of them had pre-existing cardiovascular disease. So it's going to be completely underpowered to check that it's safe in people with pre-existing cardiovascular disease. So I think we don't yet know that febuxostat is safe in people with pre-existing cardiovascular disease. I think that's my take-home message when I look at these two studies together.
Yeah, but you have two studies, both with problems, with different outcomes. And so at least they balance each other, and you can still use the drug.
Again, use your clinical acumen. All right, moving along. sodium glucose lowering therapies, the gliflozins. It sounded very Swedish when I say that, I think, gliflozin. So these are all the rage in diabetes. That we know that the side effect is that they increase uric acid excretion in the kidneys. So this study was looking at the 3 drugs, canagliflozin, dapagliflozin, empagliflozin, and the risk of developing gout in people with pre-existing diabetes. And they found that a decreased risk of gout in people on dapagliflozin or empagliflozin compared to canagliflozin, but we don't know compared to people not on gliflozin. So just interesting to know, and it may be, you know, people with diabetes and gout are on a lot of medications. If we can reduce polypharmacy, if we can use maybe one of these drugs, and it means we don't need allopurinol, presumably these improve your cardiovascular risk, they don't make it worse. So, you know, even better, we can avoid febuxostat. So it's just an interesting pearl, I guess.
Okay.
All right.
No problems.
So again, this study, dual energy CT predict cardiovascular mortality in gout. So we know people with gout are at risk of cardiovascular disease, and I think this just shows you that if you use, we know that serum urate is not a good measure of total body serum burden. That's why people that target urate will keep getting attacks for a while, because it takes a while for those tophi to dissolve. So maybe dual energy CT is a better predictor of or better surrogate of your body burden of urate deposition. And maybe we'll be using this to predict cardiovascular scores, as the New Zealand GP predict score doesn't work very well. I guess it tells us what we know though, Erwin. People with worse gout have a worse cardiovascular outcome.
I think we've now presented a number of slides suggesting gout. Really, we need to raise our game, as you said.
Yeah. Okay. Carry on. Oh, I love this one too. Oh, there's so much to love. So this is from Sarah. Her name's just escaping me. Christensen, who works with Lena Terslev and Mikkel in Denmark. And so what they did was they said, when you do a dual energy CT, the thresholds for differentiating calcium pyrophosphate from monosodium urate are theoretical. And so there may be some error. And when they looked really hard, they found that most deposits had a combination of calcium in them and urate in them. So they took the lesions most likely at the end of the spectrum, so that they were almost certainly monosodium urate and unlikely to be pure calcium pyrophosphate, and had a look at where those lesions were. And they were the lesions in the patellar tendon or the MTP1. So lesions at those 2 sites, you could be really pretty sure are definitely monosodium urate. Lesions elsewhere might be other stuff. So if you focused on the MTP1 or the patellar tendon, you're most likely to be specific for gout. The other thing they did was looked at the patients who had gout and where their lesions were. And every single patient with gout had a lesion either at the MTP1 or the patellar tendon. So basically, if you focus on those 2 areas, you're going to increase your specificity without reducing your sensitivity. So it's a reminder that these things are not black and white.
Yeah, this is interesting. I didn't realize this, but yeah, it's good. We have 9 minutes. Sorry, you have 4 slides left.
Oh, pregnancy. Okay. Do you want me to talk to this?
Yes.
Okay. So this is about, many of our patients with rheumatoid and lupus are young women. And we know that, I think, again, we're talking with Rebecca, and she was saying that about 30% of pregnancies are unplanned. I suspect some places I work it's higher. But they're risky because patients may have active disease which has worse outcomes, and they may be on medications which are teratogenic. And we should be planning pregnancies. So if you look at people, are we discussing this with our patients and are we documenting it? So the first abstract was just looking at 100,000 women aged between 18 to 45, and only 8.9% had contraception documented. And this was more likely to be documented in women and younger women and white women. much less likely to be documented in people of Hispanic backgrounds and other ethnic groups. So pretty shocking, really, that we obviously have biases that we're not aware of. Hopefully none of us are actively treating our patients or discriminating against patients from different ethnic groups, but clearly it's happening. And, you know, it doesn't take, the second abstract was really talking about how little it takes to get the conversation started. So this was a clinic in the US where they just, at every patient attending the clinic, just got 3 questions asked of them on a bit of paper. Would you like to get pregnant? Do you use contraception, and what contraception? Only 60% of them used contraception. So given 30% of pregnancies are unplanned, I guess that kind of makes sense, but it's a little bit frightening. But the other interesting thing is that 1 in 6 women wanted to have this discussion about pregnancy.
Yeah.
So
my disclosure is I'm lousy at documenting this. I always talk about pregnancy, but you know, I skirt around contraception. You know, I don't tell them to take what sort of contraception, and really this is a good reminder to do it and to ask people the questions. Yeah. Okay. It's another can of worms to open to take up another 10 minutes of the consultation time.
Yes, we've got six minutes. Afterwards,
you do well.
Yeah, okay. Pregnancy outcomes in spondyloarthropathy and spondyloarthropathy. So there's some suggestion that outcomes are bad in SPA. So this was a systematic review and meta-analysis of pregnancy and fertility data in SPA. And basically the outcome of this was that there seemed to be a higher risk of caesarean section in people with SPA, but probably largely driven by elective caesareans. So hard to know what to take from that. Slight increased risk of preeclampsia and also small for gestational age. But the biggest issue was the caesarean section from memory that they were talking about. Erwin,
no, it's just good to know, good to reassure patients really, except for the caesarean rate bit. But yeah, we need more data in this space.
Yeah, so the other study, on the right side was looking at psoriatic arthritis, much better. No increased risk of preeclampsia or gestational hypertension, no increased risk of gestational diabetes, but again, increased odds of C-section. Yeah, next slide. So this was really interesting. This was, again, this is a practice, this is a pearl for us. So large electronic health record cohort of patients with lupus. We know that people with lupus are at high risk of, have high risk pregnancies, they're at high risk of preeclampsia, and the ACOG guidelines recommend that low dose aspirin is warranted in all patients with SLE who are planning pregnancy or who are pregnant. And this just looked at what's really happening in the real world. So rates of preterm birth and preeclampsia have not changed, they've not gone down recently. So despite the fact that we're getting better, we've got better guidelines, people are still getting preeclampsia, they're still getting preterm birth. And interestingly, we're not using aspirin. So when do you use aspirin routinely in your lupus patients who are getting pregnant?
The answer is no, but I'm now more aware of the literature and I'm using it now.
Yeah, me too. I don't think I had routinely been using it. So this will change my practice. That's the point of conferences, right? So that's good. Okay, next one.
Lucky last one. This is a really good.
Make it. Okay. So this, where is the study from again? So,
Qatar.
Qatar. Yeah, that Qatar study, but I'll talk to that in a minute. So this looked at people who had been exposed to a biologic in all 3 trimesters of their pregnancy, and then the vaccination of the children, so of the babies. So these babies got vaccinated, 13 of 25 got BCG, 17 of 25 got the rotavirus at 2 months, 16 of the 25 got the rotavirus at 4 months, and 16 of the 25 got the MMR at 1 year. And basically there was no problems. These are all live attenuated viruses. There was no problems in the babies. But you know, Steph Bond presented at the ACR meeting in 2018 a really similar data. So this happens in Australia as well. Our patients take biologics. Sometimes the whole way through their pregnancy, sometimes just to the end of the second trimester, and often the babies get vaccinated. Again, from memory, there was not a big deal, wasn't a big problem, but it just reminds us we need to be talking to our patients about the risk and whether or not the baby should be vaccinated, because it's happening in Australia.
Yep, I think we talked among ourselves, and most of us will try to stop it in the 3rd trimester. I think I've had one where her disease was so bad we just continued it, and luckily it was okay. And that's the lucky last slide. We made it.
Amazing.
With 2 minutes.
Thank you very much, Erwin and Helen, for that very interesting presentation, and thank you everyone for participating.